Good afternoon, everyone. I'm Dr. Barmoshe. I'm a urologist. I'm working in 3 different hospitals in Brussels. And today, I want first to thank the organizers for inviting me for the first edition of the MedCup. And I hope it's the first of many. We're going to discuss now, we will focus today on the impact of technology in the progress of urology. So technology is a tool improving the quality of care, and it enables physicians to enhance patient diagnosis and treatment. But it's still very important not to forget the anamnesis and physical exam, because this will help you to decide in which direction you will use those tools. Because if you don't know where you're going, it's like having a nice car and you don't know where you have to go, so it's not really useful. And before the era of all the tools that we have currently, our ancestors, colleagues, had to rely on semiology. The semiology is the medical field that was analyzing signs and symptoms. And during that time, they depended only on anamnesis, on physical exam of the patients, and they had to look at the stools, the color, the smell, and also the urine. They had to check the color of the urines, the smell of the urine, and also the taste of urine. So we can say that those days we are lucky, we don't have to do that anymore, but that's how they were diagnosing the diabetes. For example, they were testing the urine, and if it was sweet, they had the diagnosis of diabetes mellitus. And mellitus meant sweet like honey. That's how they discovered it. And diabetes came from ancient Greek that meant go through. Those patients had polydipsia, so they were drinking a lot, and they had also polyuria. And the meaning of go through is that the liquids were going through the body because they ingested the liquids and directly it was coming out. So that's why they called it diabetes mellitus. And also there's another pathology that exists, is the diabetes insipidus. And it had also the same symptoms, polydipsia and polyuria. And the difference was that when they were testing the urine, it has no taste. It was tasteless. So that's why they called it insipidus. We can say that we were outsmarted by the Indian doctors, because in the 5th century in India, they were throwing the urine on the floor, and when the ants were coming to taste the urine, they knew that it was sweet urine. So that's how they made the diagnosis. So technology is everywhere. We start now first from at the level of diagnosis. You have the medical imagery with the development of X-ray, the ultrasound, the CT scan, MRI, PET scan. We use it also in diagnostic interventional radiology tools, like the ultrasound guided biopsies or MRI fusion biopsies. We all discuss about that later, thereafter. Endoscopic diagnostics tools like cystoscopy, ureteroscopy. And also in therapeutic level, in open surgery, in endoscopic surgery, laparoscopic surgery, robotic surgery today, in cryotherapy, heat therapy, all the lasers that we use. So now we will start to discuss about all those technologies. So first on medical imagery, you know about the X-ray. It was the first technology that was developed at the end of 19th century with Röntgen, who discovered the X-ray waves. And then after, we had to wait until the 50s when we developed the ultrasound. And then later in the late 70s, we had the CT scan. Like here you can see a kidney tumor diagnosed with the CT scan, and we also developed, with the evolution of the computers, were much more developed and could calculate more faster. We could develop the 3D imaging, so reconstruct the CT scan images in 3D. You had also almost at the same time, the MRI that was developed. And then in the beginning of the year 2000, we had the PET scan. And we have now at our hand different kind of PET scan. We have the PET scan using the first one was the 18 fluoro desoxyglucose, but now we have also the PET choline. We have also the PET PSMA that is used now a lot in urology because we use it in the diagnosis of metastases of prostate cancer because it's specific to prostate cancer cells. Now, we also use it as urologists for we use the ultrasound to guide us to take samples in the prostate. We use it also to take samples of tumors in the kidneys. We have also, as I show you here, the MRI fusion. It's the fusion of the images of an MRI where we could see better the prostate cancer, and then we will merge the two images with an ultrasound that we will use during the exam in the patients, and we will pinpoint the area, the specific area in the MRI, and it will appear in the ultrasound image, and then with the guide. You will go directly to the specific area and take a sample there. After before the venue of all those imaging technologies, we had to check what's happening in the urinary system. Because it's not an organ that we could access so easily, so we had to create tools to be able to access it. And what we have to know first is that the urinary system is not accessible easily, and also the access is narrow and deep. So by women, the urethra is 3 centimeters long, so it was easier to get there, but the urethra by men is around 20 centimeters. So we had to create very thin instruments to be able to reach the bladder. So there are a few rules. First, the bladder or the urinary system is a dark space, and we examine hollow organs. So the technical challenges is knowing all those rules is first we had to develop tools with vision like optics, with lenses that could enhance the image. We needed, of course, light because it's a dark space, and also we needed an expander to open the organ. In urology we use saline, but when you do coloscopy you use gas. So a bit of history in the development of the cystoscopy. You could see here the first cystoscopes that were developed in the 19th century before the era of the X-rays. So first, in the beginning, they were using optics where they could see inside the bladder, but they didn't have yet developed the light to be able to see inside. So they were using in the beginning candles where the light was reflecting on a concave reflecting surface that was going inside the optic, and then it was illuminating the bladder. And then they created another kind of cystoscope with a reservoir containing turpentine and a mix of turpentine and magnesium, and this was creating a very bright flame that created a light that was reflected here in a mirror, and then the light was going through the optic to the bladder. And then Nietzsche here created the first cystoscope where the light was at the end of it. It was a platinum wire that was heated and was creating a light inside the bladder. Here you can see the cystoscopes that we are using now, the current cystoscopes. And those ones were developed from the 50s. We had the cold light that was bringing the light inside the bladder that was developed. And then we developed also the glass fibers in the 60s who enable us to create flexible instrument in order to be able to reach the ureter and the kidney. So here you see here the cystoscope. You see here, this is the optic where you look inside, and you have here the entrance of you connect here the light cable, which brings the light towards the area that you are looking for. And you have also the entrance here of the water, the saline. This is the entry point, this is the exit point, and you need also, in order to do biopsies or to be able to grab objects that are in the bladder, if you want to take out a double gauge stent that is inside the bladder, you need a working channel where you can put a grasper inside and you can grab the objects. Here you can see on the same plans, you can see here the ureteroscope that is thinner and longer, and this gives us the opportunity to go and examine the ureter and even go to inside the kidneys. And it's built the same way as the cystoscope. You have also the saline entering and the exit also at the other side. You have here the optic, and you have even two channels of to put in instrument. You can put the laser inside also. And then with the development of the glass fibers, we could develop flexible instruments. And here you can see the cystoscope that can flex really like almost 360 degrees. You have also the flexible ureteroscopes that enables us to go inside the kidneys, and you can examine all the areas of the kidneys. Here you can see in a kidney, you can see that if we had the rigid ureteroscope, we would arrive just at the entrance of the kidney, but we could not examine the rest. So with the flexible instruments, we could go and examine all the areas, and we could also treat all the kidney stones that are everywhere in the kidneys. And here you can see with the development of the lasers, because of course if you arrive to areas of the kidneys, you need a flexible laser that could arrive. So that's why we needed the laser that have flexible fibers that could arrive until the tip of the flexible ureteroscope and then destroy the stone there. We developed before the era of the flexible instruments, we had to find a way to destroy the kidney stones because we couldn't arrive with the rigid instruments. So we created the external shockwaves lithotripsy. It's ultrasound shockwaves that are focused on the point, and the point is here the stone. And you can see here in the beginning the first lithotripsy machines. In order to deliver the shock waves, it had to go through a liquid. And they created bath where they were putting the patient inside the bath, and that's how the shock waves were transmitted to the patient and then to the kidney. And now the new machine, you can see here the new machines, where in replacing the bath, we have here a head full of liquid, and from there the shock wave is transmitted directly to the patient. We have to put, of course, gel in contact with the patient in order to allow the shock wave to go through the patient. We developed, especially in kidney tumors, cryotherapy. It's a non-invasive approach where you, when you have a diagnosis of a kidney tumor, you could treat it instead of removing the kidney. You could treat it with cryotherapy, and where you lower the temperature to minus 40 degrees, and then you destroy like this the tumor by freezing it. You have also the heat therapy. Here we use it in prostate cancer. It's we call it the HIFU, high intensity focused ultrasound. It's an ultrasound wave that with a certain frequency that will hit the prostate, or the area that you will pinpoint at around 100 degrees, and it destroys under ultrasound. It destroys the tumor, the prostate tumor. And now we arrive to the surgery. As you notice, there are different types of surgeries. There is open surgery, endoscopic surgery, there is laparoscopic surgery, and now we have the robotic surgery. In order to allow us to operate the patients with safety, because as you know, when you open a patient, there is always bleeding. And so you have to be able to control the bleeding, otherwise you are not going to be able to perform the operation. So in order for our ancestor colleagues to perform those surgeries, they needed first to develop the electrocoagulation. And the first type of electrocoagulation was the monopolar and bipolar coagulation. But then you had the ligature, the harmonic scalpel, and even now we have the argon plasma coagulation. We barely use it in urology, but it's very useful in hepatic and spleen surgery. We have now the endoscopic surgery. We use it, it's the gold standard now in urology. We use it to treat prostate hypertrophy, and also to remove tumors in the bladder. You see here, like as example here, the prostate, that's how it works. You cut pieces of the prostate, and you remove those pieces after. You have here an example of a polyp in the bladder, and you can see here the electric knife with and then with it you will cut the tumor, as you can see here. Also, we developed the laser. We use it in different kinds of pathology. We use it in the prostate. We can have like we treat hypertrophy of the prostate. We vaporize the prostate with the laser. You can see here the greenlight laser. You have other types like holmium laser also. We can use also those lasers, as we saw before, to destroy kidney stones. And now we arrive to laparoscopic surgery. Laparoscopy started in urology in the late 90s. We had the main operation, the most difficult operation in urology is the radical prostatectomy. So we started the radical prostatectomy in laparoscopy in 92. Schussler was the first one to perform radical prostatectomy in laparoscopy. He started it without any experience, so they did few cases. It was in the US. They did few cases and they stopped because they didn't saw an advantage compared to open surgery, because those operations lasted almost 9 hours with a lot of bleeding compared to the open surgery that was performed in 2 hours, maximum 3 hours. But we had to wait in 97 with a team, a French team of Bordeaux, Richard Gaston and Thierry Piéchot, who performed the first radical prostatectomy laparoscopic in France. And they were able to succeed to perform it in less time than in the US. And they were the first one to invent the technique and to improve the technique. And from that time, we started to spread the technique all over the world until the robot arrived in the year 2000. So the challenge in laparoscopy is to use this experience in the radical prostatectomy to perform it as good as open surgery. With this technique, because you could see better where you were operating, you could perfect anatomical dissection, you could improve the continence results, you could improve the neurovascular bundle preservation for the erection, and you could reduce the blood loss, the pain, and hospital stay. It's a minimal invasive approach. You have a better access to the operative field. It improves the vision and the dissection quality. It improves the continence rate and also the erectile function preservation. You can see here the laparoscopy instruments. You have here the needle driver. You have graspers here, and you have the monopolar scissors and the bipolar coagulation device. Here you can see how the patient were positioned in the operating room. This was when I took those pictures when I was visiting Professor Gaston in Bordeaux in 2005. That's how they were positioning the patients here in Trendelenburg position. You had here all the trocars with the instruments. You could see here it was the old screens. Now we have LED screens, and you can see here all the instruments. You have the suction device, you have the camera here, and all the scissors and the bipolar instruments. And now we are, since 2000, using the robots. The main one is the Da Vinci system, developed by the Intuitive company, which is an American company. This is the XI system. This is the last one, the 4th generation. And you can see here it's a 4-arm robot with 1 arm holding the camera and 3 instruments at the same time working with the camera. Here is the surgeon console, where you can put the heads here, the head here. You have here the lenses where you could see in 3 dimensions. You can see here all the different recent robots. This is the XI. This is the robot with the single port. So just one hole that you do, and all the instruments go through that hole. We'll see that later. This is the surgeon console. This is the screen for the assistant.
The Da Vinci system
and now you can see here the robot.
Surgical platform available in today's market. The Da Vinci system consists of an ergonomically designed surgeon console and a patient-side cart with 4 interactive robotic arms, one to hold and position the high-resolution stereo endoscope, and the 2nd, 3rd, and 4th arms to control high-precision, fully articulated endo-wrist instruments. While seated comfortably at the Da Vinci console, the surgeon views a magnified, high-resolution 3D image of the operative site. Powered by state-of-the-art robotic and computer technology, the surgeon's hand movements are scaled, filtered, and seamlessly translated into precise movements of the endo-wrist instruments. The net result is an intuitive interface enabling unparalleled precision, dexterity, and control.
So for the patient benefit, the radical robotic prostatectomy is a mini-invasive technique, low blood loss, lower postoperative pain, and has also early functional recovery. For the surgeon, you have the 3D vision, you have the surgeon comfort because you are in a sitting position, and also you have a precise gesture because you have no tremor transmitted to the instrument. You can see also they are articulated instrument with 7 degrees of liberty. the different instruments that were developed progressively. And we discussed also about the single port robotic robotic surgery. Here you can see one port inside with the instrument getting in through one hole. And you can see here the robot. You can see here the different instruments that were developed for the single port robot. Thank you very much for your attention.